Dr. Fiona Craig will be discussing plasma cell neoplasms. Dr. Craig is the Hematopathology Division Chair at Mayo Clinic, Arizona, and Hematology Laboratory Director at the Mayo Clinic Hospital, Phoenix campus. She has a particular interest in education and has most recently focused on flow cytometry education through the International Clinical Cytometry Society and Clinical Cytometry Education Network. Thank you, Dr. Craig, for being part of the Expert Hematopathologist video tutorial series.
Hello, I'm Fiona Craig, and in this video I'm going to describe my approach to the evaluation for plasma cell neoplasms. Let's start with a clinical case. A 64-year-old woman was found to have monoclonal gammopathy and had a bone marrow performed to evaluate for plasma cell myeloma. Review of laboratory studies confirmed the presence of a monoclonal protein, and immunofixation electrophoresis further characterized as IgG heavy chain and kappa light chain. Serum-free kappa light chains were elevated. However, serum calcium was within normal limits, the patient was not anemic, and a bone scan was negative for lytic lesions. So what are the possible considerations? It's important to broaden the differential diagnosis and consider possibilities other than myeloma. Perhaps this represents a different category of plasma cell neoplasm, such as primary amyloidosis, or maybe lymphoma with plasmacytic differentiation. Resolving this differential will require integration of the clinical, morphologic, and other findings. The key finding for a diagnosis of a plasma cell neoplasm is the presence of clonal plasma cells, usually identified by monotypic expression of kappa or lambda light chains. However, in order to distinguish from lymphoma, it's also important to demonstrate a plasma cell immunophenotype characteristic of a plasma cell neoplasm. Features important for a diagnosis of lymphoma include identification of B lymphoid cells with monotypic expression of immunoglobulin light chains, or an aberrant immunophenotype. As discussed later, the neoplastic plasma cells present in lymphoma with plasmacytic differentiation have a different immunophenotype than those found in a plasma cell neoplasm. Finally, flow cytometric studies may assist in identifying the coexistence of both a lymphoid neoplasm and a plasma cell neoplasm, such as monoclonal gammopathy of undetermined significance, plus monoclonal B lymphocytosis. So as we start looking at the case, it will be important to identify plasma cells and lymphoid cells, determine their proportion, evaluate for clonality, and determine their immunophenotype. Evaluation of the peripheral blood smear demonstrates rouleau, reflecting the increased serum protein. There are a few lymphoid cells with an eccentric nucleus imparting a somewhat plasmacytoid appearance. However, on closer inspection, it can be seen that this cell is a large granular lymphocyte. LGLs are often increased in association with a plasma cell neoplasm and do not provide any additional diagnostic or prognostic information. Of course, it is important to recognize circulating plasma cells and, if present, determine if they meet the numerical criteria for plasma cell leukemia. That is, an absolute plasma cell count greater than 2 × 10⁹ per liter, or plasma cells that represent greater than 20% of total circulating white blood cells. The aspirate smears are cellular and demonstrate an abnormal infiltrate, replacing many of the hematopoietic elements. Higher magnification reveals markedly increased plasma cells, in addition to a few maturing erythroid and neutrophilic precursors. Many of the plasma cells appear abnormal with cytoplasmic vacuoles. Plasma cells represent 65% of cells identified by manual differential count of aspirate smears. These findings indicate bone marrow involvement by a neoplasm with plasmacytic differentiation. Of interest, in some areas, the infiltrating cells have a more varied appearance, including plasma cells, lymphoid cells, and cells with intermediate features. These morphologic findings raise the possibility of lymphoplasmacytic lymphoma. Flow cytometric studies were performed and can help to determine if this is a plasma cell neoplasm, lymphoma with plasmacytic differentiation, or perhaps both a plasma cell neoplasm and a lymphoid neoplasm. The top row of flow cytometric dot plots demonstrate B lymphocytes with the expected strong staining for CD20 and CD19, lack of the plasma cell markers CD38 and CD138, and polytypic expression of surface immunoglobulin. So there's no evidence that this is a lymphoid neoplasm. The lower row of dot plots demonstrates plasma cells that have cytoplasmic kappa light chain restriction and an abnormal immunophenotype with variable expression of CD138 and CD38 and variable expression of CD20 without CD19. These findings are typical of a plasma cell neoplasm rather than neoplastic plasma cells that are part of a lymphoma. Of note, there are a few plasma cells with a normal immunophenotype, best seen on these plots by the few lambda-positive cells. But these are a minority, with abnormal plasma cells representing greater than 95% of total plasma cells. This table summarizes the features that can be used to distinguish plasma cell neoplasms from lymphoma. The flow cytometric findings are the most definitive. Plasma cells from a plasma cell neoplasm are usually CD45 negative and lack B cell antigens CD19, CD20, and PAX5. In contrast, neoplastic plasma cells that are part of lymphoma express CD45 and a full pan B cell repertoire. Heavy chain expression is quite variable, but IgM is less frequent in myeloma and should at least raise the possibility of lymphoma or monoclonal gammopathy of undetermined significance. The appearance of the neoplastic cells can be deceptive, with plasma cell neoplasms sometimes having a more lymphoid appearance, as seen in our case, and lymphoma occasionally showing plasmacytic differentiation. Another feature that may be useful is the presence of paratrabecular aggregates that may be seen in lymphoma affecting the bone marrow. In plasma cell neoplasms, the cells with a lymphoid appearance are usually intimately admixed with those that have more of a plasmacytic appearance, whereas in lymphoma, plasma cells may surround the lymphoid aggregates. And finally, aneuploidy is more often seen in plasma cell neoplasms than lymphoma. Flow cytometric studies can also identify immunophenotypic abnormalities that help to distinguish a plasma cell neoplasm from reactive plasma cells. For example, plasma cells from a plasma cell neoplasm are usually CD45 negative, CD19 negative, and often have weaker intensity staining for CD38 than normal plasma cells. Plasma cells may also express CD20, as seen in our case example, but usually do not express the combination of CD45, CD19, and CD20 more typical of lymphoma. Identifying plasma cells with an abnormal immunophenotype by flow cytometry is particularly useful when they represent a small proportion of total cells, such as for monoclonal gammopathy of undetermined significance, or if the aspirate is hemodilute and not representative of a more overt plasma cell neoplasm, or perhaps if there are very few plasma cells following successful therapy. The next slide discusses how flow cytometry can also provide prognostic information. The identification of minimal residual disease following therapy is an important prognostic marker and will be discussed later. In addition, the proportion of abnormal plasma cells at diagnosis can provide useful prognostic information. Multiple myeloma is often associated with relatively few residual non-neoplastic plasma cells, whereas MGUS and smoldering myeloma usually have more numerous residual non-neoplastic plasma cells, so that abnormal plasma cells represent less than 95% of total plasma cells. Although this information is not used in establishing a diagnosis, it can help to predict prognosis. MGUS or smoldering myeloma with fewer normal plasma cells than expected has a higher risk of disease progression. Although the immunophenotype of plasma cells in myeloma has also been associated with prognosis, this information is rarely used in therapeutic decision-making. Now, let's return to the case. The biopsy sections demonstrate cellularity of approximately 60%. There is an abnormal infiltrate with many plasmacytic cells. At higher magnification, the abnormal infiltrate displays a lymphoid appearance, similar to that seen in the aspirate. Trilineage hematopoiesis is present, but decreased. The aspirate clot preparation demonstrates similar cellularity. And at a higher magnification of the aspirate clot section, you can see the infiltrate of plasma cells. It's important to assess the proportion of plasma cells in all components of the specimen, including the aspirate clot or particle preparations. In addition, it may be useful to have archived non-decalcified aspirate material, so that this can be used for additional studies, such as mutational analysis, or as a baseline for future molecular assessment of minimal residual disease. Determining the proportion of neoplastic plasma cells is useful for diagnosis and monitoring. Although this is often difficult to determine with accuracy, it's useful to consider relative to some important thresholds. In a patient who does not have myeloma-related organ or tissue impairment, such as hypercalcemia, renal insufficiency, anemia, or bone lesions, 10% plasma cells is used to distinguish MGUS and smoldering myeloma. For a patient with smoldering myeloma, like the one presented here, a threshold of 60% is often used to identify a high-risk disease, which might benefit from initiation of therapy. Flow cytometry often underestimates the proportion of plasma cells, and therefore at diagnosis is used more for qualitative assessment rather than quantitative information, as described earlier. The aspirate differential may also not be entirely representative, perhaps due to difficulty in aspirating larger plasma cell aggregates, and a bias in selection of the areas to count. Therefore, it's best to evaluate all specimens for the proportion of plasma cells, including the aspirate clot and biopsy, and describe any discrepancies in the report. A CD138 immunohistochemical stain can be of value if difficulty is encountered in distinguishing abnormal plasma cells from maturing myeloid cells on tissue sections. Do cytogenetic studies have a role in the evaluation for plasma cell neoplasms? As listed in this table, cytogenetic abnormalities have been used to distinguish low, intermediate, and high-risk myeloma. Similar but slightly different tables have also been described in smoldering myeloma. Therefore, evaluation for these abnormalities is useful at diagnosis and relapse. Which cytogenetic studies should be performed? Classical karyotyping studies are less than optimal because plasma cells do not grow well in culture and abnormal findings are often cryptic. However, it is important to perform classical cytogenetic studies if there's also concern for a myelodysplastic syndrome or a therapy-related myeloid neoplasm. Although fluorescence in situ hybridization studies are preferred, it's essential that these FISH studies are performed following plasma cell enrichment. Without this important selection method, FISH studies often give false negative results. There are several methods available for plasma cell enrichment, including combining FISH with morphology, light chain expression, or CD138 selection. For the case example, light chain restricted plasma cells were evaluated and demonstrated the following findings. Rearrangement of the immunoglobulin heavy chain gene was identified using a break-apart probe. IGH CCND1 rearrangement was identified using double fusion probes, as shown here. An immunohistochemical stain performed on the aspirate clot preparation demonstrates overexpression of cyclin D1, as expected as a result of the CCND1 gene rearrangement. Plasma cell neoplasms with CCND1 rearrangement represent approximately 20% of myeloma, but this finding can also be seen in MGUS. Plasma cell neoplasms with CCND1 rearranged often have a more lymphoid appearance and can express more B-cell antigens than is typical for myeloma, such as CD20. These features can raise the possibility of lymphoma, and if cyclin D1 expression is identified, might lead to an erroneous diagnosis of mantle cell lymphoma. In addition to flow cytometric and cytogenetic studies, there is an evolving role for gene mutation and expression studies to determine prognosis. Therefore, it might be prudent to extract and store DNA and RNA, or at least prepare an undecalcified aspirate clot or particle block for potential future studies. Once a diagnosis of a plasma cell neoplasm has been established, there are an increasing number of therapeutic agents, including proteasome inhibitors, immunomodulatory therapy, and monoclonal antibody therapy. Bone marrow specimens are often obtained to evaluate for response to therapy, with the goal of keeping the disease at a low level rather than obtaining a cure. The International Myeloma Working Group established response criteria and updated them in 2011 to include evaluation for minimal residual disease. Flow cytometry is one method available for the detection of minimal residual disease following therapy, and with recent modifications of the procedure, such as bulk lysis, can reach a sensitivity of 0.001%, or 1 cell in 10 to the 5. The first step is to identify plasma cells and then evaluate for the characteristic immunophenotypic abnormalities described earlier. Although CD38 and CD138 are useful antigens for the detection of plasma cells, their utility in the lab may be limited if the patient has received monoclonal antibody therapy directed against those antigens. Therefore, there is ongoing investigation for alternative plasma cell markers, such as CD319. In summary, I'd recommend considering flow cytometry when evaluating a bone marrow performed for monoclonal gammopathy. Evaluate the proportion of plasma cells in all components, such as aspirate smears, biopsy, and aspirate clot preparations, and add immunohistochemistry if you're uncertain of the proportion of plasma cells, particularly if they appear close to the thresholds of 10% and 60%. Allocate material for prognostic markers and only use FISH studies that have a plasma cell enrichment step. If following therapy there are only a few plasma cells, pursue studies to identify minimal residual disease, such as flow cytometry, PCR, or next-generation sequencing. Thank you.
Thank you, Fiona, for this comprehensive discussion of plasma cell neoplasms.